Gretchen Kudik-Rowan, Senior Editor of Practical Cardiology, and in today's installment of our COVID video series, we'll be talking with Mitch Elkind. Dr. Elkind is a tenured professor of neurology and epidemiology at Columbia University, and we'll be discussing the neurological presentations of COVID patients. It's a fascinating discussion that I'm sure you'll enjoy, so stay tuned. Dr. Elkind, welcome, and thank you for joining me.
Thank you very much for having me, Gretchen.
So I'm here to talk to you about something kind of curious, which is what's going on neurologically with patients who have COVID-19. So apparently we're seeing an increase in both stroke and seizure. What's happening there? Can you give me some information about what we're seeing, and then maybe a little bit about what we think is happening?
Sure, yeah, so that does seem to be an issue that's arising, which is that neurological problems are occurring in patients with COVID-19. And I think there are a number of different ways in which this seems to be happening, so that patients who have neurological disease may have worse outcomes if they become infected with the coronavirus. There's also some evidence that this coronavirus may have direct effects on the brain. And in addition, we see that some patients seem to present with neurological symptoms without any fever at all. And that can be very challenging too. It's possible, we don't know this for sure yet, but it's possible that some patients have a neurological presentation of COVID-19.
It's fascinating because we're seeing similar things with the cardiovascular system, for example, that patients are coming in with cardiovascular complaints and no respiratory symptoms at all, at least initially. And so we're beginning to think that, this is a heart attack or some other kind of heart failure issue, but it turns out it's COVID. So you're seeing something similar is what you're saying in the neurological side.
Exactly. I think it's not quite as common, but it does seem to be happening. I think just today in the New York Times, there was a big report about our EMS services seeing people with cardiac arrest, at the site, at their homes, or, when they're out, and finding that they may have COVID as kind of the underlying cause of their cardiac arrest. So it seems to be happening a fair bit with heart disease. And I think we're just now beginning to see that with neurological problems as well. The way that this virus gets into cells is through this receptor called the ACE2 receptor. And that receptor is found in lung tissue. I think it's also pretty clear that it's found in heart tissue and in what we call endothelial tissue, the tissue that's lining the blood vessels. And that's thought to be one of the reasons why it may injure the heart and why we see so many cardiac manifestations like arrhythmia and cardiac arrest and direct heart injury. But that receptor is actually also found in nerve cells too. And so there's some concern that, sure, the virus may be getting into nerve cells. This virus is very similar to the original SARS virus, the SARS coronavirus that had the epidemic back in 2002. It's very closely related to it. And there's been, many years of research with that particular virus. And so people have found that that virus could actually invade the central nervous system. It could be found within brain tissue. And so the concern is that this one may be doing that to some extent as well.
Is there any worry that, let's say that the virus could invade neurological tissue, that we might not see effects immediately, that like someone who has a neurological presentation, maybe they are not showing up with it until, they're not coming down with respiratory symptoms. Maybe it's not showing up at 10 days or 14 days, but maybe 2 months later or 6 months later when it really has time to damage the brain cells and have a larger effect. I mean, is that something that you're talking about or thinking about?
It is something that we're thinking about. I mean, to be honest, this disease itself is only 3 months old, so it's a little bit hard to talk about what we're going to see, 6 months from now. But absolutely, that is at least a theoretical concern. There've been a few case reports now from China and even in the United States of patients who have what we call encephalitis, So this is a direct inflammation of the brain. And the scans, the brain scans of these patients have been published and posted, and we're all talking about this. And in those very few cases, right, there are, there are over 1 million cases of COVID now, right, worldwide, and just a few case reports of encephalitis. But those scans show very severe injury to regions of the brain. And so there is concern that for whatever reason, in some people, the virus gains access to the brain and causes damage. Those are acute cases, so that is within a relatively short period of time. But yes, absolutely, we are concerned about the possibility of long-term problems. That is what happened after the 1918 flu pandemic. There were cases of encephalitis there, and many of them only manifested much later with their symptoms. People developed what we called post-encephalitic Parkinsonism. So
Oh,
the
right. That's
damage, remember that?
from the actually the movie Awakening. Actually, that's what he had, right? He had post-encephalitic Parkinsonism.
That's exactly right. Yeah. So, it caused a damage to the brain, and those patients survived, but they were left with a Parkinson's-like syndrome. And so we know that that can occur. And so but we don't know if that's going to happen with this virus yet. I think the neurological complications are much less common, but they are certainly possible. It's very interesting, right, that one of the main manifestations or symptoms of this virus early on seems to be a loss of sense of smell. You've probably seen that. It's been reported pretty widely in the newspaper and stuff.
Right. That seemed initially like it was some sort of, freak side bit, but you always have to wonder whether or not that actually that has some meaning, and probably does, right? So
Well, we think it does. It seems to be fairly common. It's funny, looking back at the Chinese reports, they don't report that often. It definitely was noted, but it was quite rare. And yet it seems like that happens a fair bit here. I don't like to talk about anecdotes, but I can tell you, I'm talking to a lot of my friends and family about this. And I get many calls from people saying that, they have a cough. And the weirdest thing is I lost my sense of smell. And, so-and-so can't taste anything. And it's really happening a lot. And so I think that is a prominent feature of this. And very unusually, it seems to be in the absence of congestion and typical nasal symptoms. So it's not just that they're blocked up, which raises the question that this may in fact be injuring the olfactory nerve, the nerve that supplies the sense of smell, which happens to be located just above the nose. For obvious reasons, sensation of smell comes through the nose and goes to the brain through there. So it seems like it could be a direct injury to the nerve there. And we know that the first coronavirus that caused, SARS back 20 years ago, that one did also seem to cause a neuropathy or damage to the peripheral nerves. And so, we certainly haven't worked this out yet, but there are a lot of very interesting suggestions or clues that this may cause some kind of direct neurological injury.
Are the ACE2 receptors on nerve cells, are they in any specific part of the nerve? Like, are they only along the axons or dendrites, or and does that give you any idea about how they might be affecting nerves, or which types of neurons might be more affected than others?
So from what I've seen is that these can be found in the brain stem. So not even in the peripheral nerves in the rest of the body. I think most of the work has been looking at autopsies, looking at brain specimens, in people who have died obviously with the disease. And that's where, and in animal models too. So they've looked in mice, for example, and they found that the brain stem, the base of the brain, is what seemed to be particularly affected. Although some of the areas like the hippocampus, which is in the middle of the brain, that's responsible for memory function, also seem to be involved. But what's interesting about the brain stem is that that's also the part of the brain that controls breathing and cardiac function. It's kind of, the autonomic pathways that go to the rest of the body pass through there. And so people have speculated, not known yet, but there's some thought that that may be why respiratory failure seems to be so prominent in this disease. Obviously, there's lung disease, but that difficulty with breathing may in part be related to that kind of injury. And there's also the other thing that my colleagues in the intensive care unit tell me is that many of these patients seem to be relatively stable from the point of view of their lung disease, and then they have a cardiac arrest. Almost out of the blue. I mean, obviously, these are sick people who are subject to problems, but sort of compared with other patients they've seen who have lung disease, severe lung disease, they seem to have cardiac arrest out of proportion to that. And so one thought is that it may be partly the autonomic nerve involvement that's contributing to that rather than just a secondary phenomenon of having severe lung disease. So there are a lot of questions that I think we still have to, work out and answer about this.
Yeah, those pathways of figuring out what's causing what, it's tricky, isn't it?
It is very tricky. And, the other possibility here, of course, is that these are patients who have acute respiratory distress syndrome, ARDS, very severe lung injury. They're in the ICU for days, if not weeks, of continuous ventilation. Anybody in that situation develops, various problems. You can develop a nerve injury just from being basically bedbound for that long and on the ventilator, and the nutrition is not the same. People can develop secondary infections, whether it's a urine infection or bacterial lung infection, or they can develop problems with bed sores and things like that. So all of that can lead to secondary damage, which may end up hitting the brain as well. And kind of along those lines, another thing that has been seen, at least from talking to my colleagues and looking at some of the biomarkers, is hypercoagulability, so an increased tendency of the blood to clot. And so that sets people up for ischemic strokes or blockages in the blood vessels in the brain, as well as venous clots. So, there's so many different ways in which a critically ill person with coronavirus can get sick that it's hard to know which is operative in all cases. They're probably all contributing.
Well, I mean, I imagine that it also makes it not just hard to diagnose, but also hard to figure out in which way you treat them, right? Like if you assume that someone's in massive respiratory distress and they're, then stabilize them on a ventilator and you're thinking, okay, we've got this part stabilized, you're really not on the lookout for a massive heart attack that might assume. So, that suddenly shows up, or that they're going to have a stroke because you think you've stabilized the patient. So it must present a very large challenge to the team of doctors and nurses that are caring for them to be aware of all of these potential possibilities and know even really exactly what sort of subtle thing to look for.
Yeah, and we're all learning together, and people are sharing information on social media and, as I said, in the newspaper and things like that. A lot of it hasn't made its way into journals yet, right? So we're kind of learning on the fly with this disease. And people are telling each other what to look out for. But I think you're right. Many of these people are, I think the public has a sense that the main problem is breathing, and we just need more ventilators. And if we had ventilators, we could breathe for people. And all right, so you need to be on a ventilator for 2 weeks, then you get better and you come off it. But what we have found is that a lot of these patients actually develop this cytokine storm that you've probably heard about. And essentially what that is a severe release of molecules that increase inflammation throughout the body. So the problem may start in the lungs, but when there's a cytokine storm, it can go throughout the entire body. It affects the heart, the brain, the kidneys, essentially everywhere. The blood is just filled with inflammation. And so some of that increased tendency of the blood to clot and secondary damage to the brain and other organs probably comes from the cytokine storm. So people look out for that, of course, when they're in the intensive care unit. Fortunately, I would just say, fortunately, those kinds of complications they're the worst, but they're pretty rare, so that is if there is any silver lining, I think that's one of them.
I'm just wondering as well, when you were talking about the ACE2 and pathway for this to enter the cells, for the virus to enter the cells, do we know anything just from previous understanding of the way, say, some of these drugs, I mean, we have drugs that affect those systems. So did we know anything about the genetic distribution? Like, are some people more susceptible than others because they have more ACE2 receptors than another person, right? I mean, I'm assuming that we just may not have any information about this, but it certainly begs the question of whether or not there are genetic, different genetic distributions among the population, I guess is what I'm trying to say.
Well, where I've seen the most written about this issue with the ACE2 receptors being different from one person to another is with regard to high blood pressure. So there does seem to be an overrepresentation of people with high blood pressure with COVID-19, and high blood pressure is one of the factors that seems to increase the risk of bad outcomes in the disease. And that's hypertension is very common. But it's not kind of the first disease you would think of as causing a problem with a respiratory illness. And it seems like hypertension is even worse for outcomes than having underlying lung disease in some patients. So one place in which I've seen interest in this idea with the ACE2 inhibitors is with hypertension. And people have thought that high blood pressure can lead to an increase in the ACE2 levels, and that may be what's making people more susceptible to it. Part of it may be that people with hypertension take ACE inhibitors, right? It's a very common medication that we use for high blood pressure. And those medicines, because they block ACE2 or ACE, the body reacts by producing more receptors. It says, hey, where's all the, where's the molecule I'm looking for? I better make more receptors.
Right.
And so it upregulates that receptor. And then that may be what's making people on ACE inhibitors more susceptible to the infection. That is still pretty speculative. And, it's kind of a funny quirk of nature that the ACE inhibitors also seem to have a benefit in lung disease. This has been known about for a little while. People with other types of viral pneumonia seem to do better with ACE inhibitors. And so right now, there's no recommendation to stop ACE inhibitors because they may have benefits as well. And so the recommendations from the American Heart Association, the American College of Cardiology, and the Heart Failure Society of America specifically say, don't stop ACE inhibitors in patients who are on them because they may be doing good, even if there's some theoretical evidence that they increase the risk of COVID-19.
Well, it sounds like because we have so many different systems working at the same time, that something that might be beneficial in one system might be detrimental in another. So it's really difficult at this point to tease those things apart, I imagine, and just we're taking it day by day.
Yeah, I think that's true. We have a lot to learn yet about this. I will say again, as a silver lining, one thing that I've seen is just the tremendous productivity of the scientific community. Many people shifting their labs and their clinical research activities to study this disease. It's really been breathtaking. People have shifted on a dime to study this. There's, I think, well over 400 papers that have been published on the topic already. The American Heart Association put out a call for grants related to COVID-19, and we received over 400 applications.
Wow.
So yeah, right. I mean, people, for obvious reasons, people recognize the crisis that we're in, and they're putting all their efforts into trying to solve this problem.
All right. Any last thoughts about this, what's going on with the seizures or the neurological symptoms that we didn't touch on?
So I would say that, one other thing to bear in mind is that in the setting of a crisis like this, there are difficulties for patients, obviously, to access care. As we all shift our hospitals to caring for patients with COVID, there's the concern that patients who have strokes or heart disease unrelated to COVID will somehow be missed or ignored. I think it's important for patients to know that if they have stroke symptoms, if they have cardiac symptoms, they should still seek help immediately. We're trying to keep people out of the hospital when possible so they aren't exposed to the virus. We're doing a lot more telehealth and other ways of reaching people. But if you have a sudden stroke, if you have a sudden cardiac event, you still have to seek help, acutely and be taken care of. But one thing people may want to be mindful of is that because it may be more difficult to get to the pharmacy or to see your doctor, it's probably a good idea to have some additional medication on hand. If you're a patient who regularly takes medicine for high blood pressure, diabetes, heart disease, stroke, etc., make sure you have those medications available, because it may become a little bit more difficult in these coming weeks and months to get what you need. So be prepared, not only with food and other things at home, but also with medication.
Okay, well, thank you so much for your time. I really appreciate it, and stay safe.
Thank you. You too, Gretchen. Appreciate it.
All right, bye-bye.
Bye-bye.
Thanks for watching. I hope you enjoyed this video. For more cardiology news, please check out our website, practicalcardiology.com.